require more attention in our clinical practice. So to strengthen and brush up our knowledge, we have today our speaker, Dr. Mahadevbhai, and we have kept the topic anemia. Thank you. Kamlesh.
Thank you, Dr. Darbar sir. Today we have a topic, an approach to a case of anemia, and we have an eminent speaker, Dr. Mahadevbhai Desai sir. He is a senior consultant at KD Center, Ahmedabad. He did his MBBS and MD from MS University, Baroda. He has teaching and professional experience of more than 40 years, and he had honorary editor Gujarat Medical Journal in 1999 to 2000, and he has awarded Dr. B.N. Mehta Oration by AMA in 2012. So I request Dr. Mahadevbhai Desai sir to start his session and enjoy this session, each and everyone, very well. Thank you, sir. And welcome also.
Yeah. Are my slides visible?
No.
No, sir.
Now?
Yes. Yes.
Right. So good afternoon, everyone, and thank you very much. It's indeed a great pleasure to be with IMA College of GP once again. Last year, we started with the first topic of preparing for monsoon illness. I am thankful to Dr. Darbar, Dr. Mehul Shah, Dr. Dheeraj Mehta, and office bearers for giving me an opportunity to open a new skill, new inning. And today's topic specifically is approach to a case of anemia. This topic is prepared keeping the family practice in mind at the first outset, I would say so. My disclosures, I am not a hematologist, I am not a pathologist. I gratefully acknowledge all the website sources or pictures that I have included in my presentation, and there is no conflict of interest as far as whatever I say, whether I talk about any of the preparations that we may talk in the later part of the discussion, any specific drug products or investigation, it's purely academic point of view and nothing personal. I dedicate this talk to the National Health Mission, which has started the Anemia Mukt Bharat in 2018. This is a very good initiative by Government of India, which was started in March 2018, and wherein 50% of the eligible populations are covered with the help of ASHA workers and the primary health centers. And the beneficiaries are divided into 6 categories. And if time permit, we'll talk about the Anemia Mukt Bharat later on. We begin with, as Dr. Darbar has rightly said, the family physician's dilemma in a busy OPD is there are more number of patients, less time available for a particular patient, and it's economically not viable to spend more time, just like the luxury we have as a consultant in our OPD, because we see number of patients much less than what the family physicians see. But let me tell you that family physicians have their own bags of advantages. They know most of the patients very well. Not only they know the patients, but their families, their generations they know. They have so much knowledge about their background. Then most of the illnesses, as Dr. Darbar rightly said, they are acute illness, short illness, whether it's a fever, cough, cold, diarrhea, or vomiting of a very short durations. And most of the patients can be called off for a very short notice. They may be called even in the later part of the day or next day, which we don't have that luxury. And there is a mutual trust between the family physicians and the patient. So these are the clear-cut advantages of the family physicians. But let me remind you about a danger, that let us be aware and beware that these days, these are the days of consumer activism. And if we miss a diagnosis, we know what can happen. So just because we know somebody for years, somebody though you know the family and background and there is a trust, you just cannot take it for granted that if we miss a diagnosis, even if patient doesn't go to the consumer court, but we ourselves would feel it, that had we even got just one serum creatinine, or whether we had referred to the cardiologist at the time, or whether we had given the intravenous iron rather than the oral, we would have probably helped the patients or reduce his hospitalizations or cost of the treatment. So it's very, very important that we know about what to do for patients of anemia. Let me start with summary of what I'm going to talk and what is the take-home messages. Just please remember, anemia is always a working diagnosis. It's never a complete diagnosis. If somebody says only anemia in any exams, I am sure we would not give them full marks, because anemia, there can be more than one cause, and there may be one type of anemia even given patient. And hardly any patient needs hematinic on day one of diagnosis of anemia. The point is, it's better they investigate first and then treat. Prescribing a patient of anemia with iron B complex do not solve the problem, right? In fact, it complicates the problem. When it comes to investigation, we will know that if we give one tablet of iron or B complex to the peripheral smear, the RBC indices, all picture will change. So it's better that we don't do that, and rather at least draw the blood first before starting a treatment. And very importantly, that now that we have got plenty of iron preparations are available in parenteral form, it's a very safe but underutilized option. And earlier, as in the beginning, I said that we have a problem of revenue when it comes to the seeing a less number of patients by way of this. But let me tell you, giving parenteral iron can definitely be a good source of income at the family practice, and it will save the patients for the money for the patient also, because for that particular IV, parenteral IV, he might have to spend more if patient has to go to a hospital, right? And very importantly, whenever you treat a patient of anemia, follow-up investigations are equally important to know whether our treatment has worked or whether we are missing something. So it's very important we keep these points in mind, and I'll definitely remind this before we close. So as Dr. Darbar has rightly said, we have decided to make it a case-based approach. So I'll just give you two cases, right? And we'll discuss about that. So first case is a female, 29 years. She is from a tribal community. She had history of multiple pregnancies. She complains of weakness, edema over the legs, menorrhagia, constipation, weight gain. There is also pillar. Pulse is 60 per minute. Her blood pressure is 146 by 94 millimeters of mercury. On examination, she has koilonychia, bilateral pitting edema. She has a systolic murmur, but there is no lymphadenopathy. There is no hepatosplenomegaly. So a female patient coming in OPD with a history, 29 years with a history of multiple pregnancies from a tribal community. We know that we have so many patients by the age of 29, they will have multiple pregnancies. It's not an unusual case. And one of the complaints are menorrhagia, constipation, and weight gain. Keep these points in mind when we discuss about the possible cause or causes. And she had pulse of only 60. She is anemic and her pulse is only 60. Her blood pressure is 146 by 94. On examination, she had spoon-shaped nails and bilateral pitting edema. But luckily, there is no lymph nodes, no spleen, no liver enlargement. So what are the possible causes of anemia in this particular case? We may wait for a few seconds and let there be opinion about what they may write in the chat box if it is possible, or I would like the panel members or the members present in the room to say what could be the possible cause. I'll be happy to have their inputs. Dr. Darbar, Dr. Kamlesh. I'll just give you again what is the case. She is a patient with a 29 years, tribal community, multiple pregnancies, menorrhagia, constipation, weight gain. Pulse is 60, blood pressure is 146 by 94. She has the spoon-shaped nail and no hepatosplenomegaly or lymphadenopathy. Yes, Dr. Kamlesh Bhai.
Iron deficiency anemia.
Correct, that is one. What else?
Second can be hypothyroid.
Very good. Yeah, very good. Yes.
Yeah.
What else?
Mainly the nutritional anemia, maybe.
Nutritional, yeah, very good. Correct. Then anything else?
Patient is having menorrhagia. So
Yes.
constipation, even.
Weight gain.
So we have to rule out this some nutritional plus some worms or something also.
Very good. Excellent, excellent. So we can say that a possible causes of anemia in this case is not one. Dr. Kamlesh is right. It's an iron deficiency anemia. But what could be the cause of iron deficiency? Blood loss, menorrhagia, yes. Worms, Dr. Darbar said. nutritional, Dr. Dhirenbhai said, hypothyroidism. A patient who has got a constipation, menorrhagia, but weight gain, and her pulse is only 60 per minute. We don't expect a pulse of 60 with patients who is not on beta blockers or certain drugs, or patient who comes just walking like that with a severe anemia. We expect pulse is on the higher side, maybe 90, 80, 90, 100, right? And hemoglobinopathies, one that we can also additional add because she is from a tribal community where we know there are so many cases of hemoglobinopathies, right? And one more, chronic kidney disease. Her blood pressure is 146 by 94 millimeters mercury. So the point to be driven is that whenever we see a patient of anemia, we need to think of the type of anemia and cause or causes of anemia. It's very, very important that we think of all these causes and look for it for when we investigate, because then only we'll know that what whether we have treated correctly, empirically. That's it. Let us take another case. Here I am already highlighting the points which are important for diagnosis. Male, 67 years, is a known case of ischemic heart disease. He had history of piles. He is receiving aspirin. He is on metoprolol. He is also receiving hematinics. He is complaining of fatigue, weakness, dyspnea on exertion, constipation, melena, weight loss of 6 kg in 2 months. He is also anemic, but this time he has clubbing of fingers. His pulse is 60 per minute. He also has bilateral pitting edema on the legs, but he also has got tender hepatomegaly, and he has a systolic murmur. So some of the signs and symptoms are kept specifically same, right, in both the cases, right, whether the pulse is 60 or whether there is constipation. So what do you think, Dr. Darbar, Dr. Dhirenbhai, or Dr. Kamlesh Bhai? What do you think? What are the possible causes of anemia?
The first and foremost, this is, I think, because of piles, it is blood loss. Aspirin is again
right.
going to cause the melena because of acid peptic disease or ulcer.
Right, right.
And the
Drug
third
induced
cause
also.
Yeah, drug induced.
it's a chronic iron deficiency anemia,
Right,
because of clubbing. And
right.
then last, we may, because the age is 67, so may have to suspect some malignancy also.
Excellent,
Yeah.
excellent. And that is why
Weight
we have
loss
put
is
the
there.
weight loss. Yes, yes. So here the possible causes of anemia in this patient could be again blood loss, right? Aspirin, piles, history of piles has a blood loss. Then his pulse is 60 here is probably because of metoprolol and not because of
Yeah.
the hypothyroidism.
Diabetes.
Here's weight loss.
Mm.
And second thing is clubbing of fingers is very important pointer towards the malignancy to be ruled out. Any elderly patients with blood loss, with or without weight loss, it's very, very important we keep in mind, right? And this is a patient who has got failure. He has edema with tender hepatomegaly. So that also we have to keep in mind when we treat that the earlier patients probably has anemia and hypoproteinemia. There was bilateral pitting edema. But here there is an hepatomegaly which is tender, is probably because of the heart failure. So heart failure patients with anemia definitely need treatment slightly different than the treatment that we give in most of the patients, because they already have nausea, vomiting. Giving them oral iron may not suffice, or in fact, they may not be able to take the oral, and then comes the role of parenteral iron. So these two cases, I just want to emphasize that the patients of anemia can present with almost similar symptoms, but they have more than one cause. And unless we treat the cause which is leading to anemia, we may have treated the patients half-heartedly. We may achieve the hemoglobin level to 13, 15 for a short time, but again, during the course of the time, the patients would again become anemic. So we have to have a checklist of history of whenever we see a patient of anemia. I would definitely ask, even if in a busy practice, I don't think this would take more than a minute. We must get the history of blood loss from any site, whether it is especially the hemorrhoids, the piles, hematuria, melena, that have hemoptysis are questions, and female patients, menorrhagia. We must ask this. Then any history of weight loss. It's better to have the weight mentioned in every visit. We must mention the weight. So even if the patient doesn't say, our weighing scale will say that patient has lost weight. Whether there is an history of fever, altered GI movements, elderly patients with altered diarrhea and weight constipations, again a pointer towards the malignancy. GI malignancy is very, very masquerading. Unless we have a high index of suspicions, they may take a very long time to diagnose. colonic malignancy especially. Then, of course, as a family physicians, you would be knowing about the patient's diet and whether it's vegetarian, non-vegetarian, but history of pica, something that patients eat which is not a food, whether it's a chalk or it's a mud or anything that we see even in our practice, we see patients, mother and daughter both are ordering from Amazon every week tons, kgs of the chalks that we have two families I treat right now have got the history of pica. So it's not that the pica is something that we see only in the children, even in adults also they have history of pica. And if they have a habit of taking the ice, it is called pagophagia. And always remember about the drugs, especially patients are in the habit of taking so many drugs. After COVID, they have to become admins, the NSAID specials and chikungunya, and they keep on taking because they get relief. They have so much consumption of NSAIDs. And unfortunately, in our cases, they are available over the counter without prescription. So diclofenac, ibuprofen, nimesulide are one of the popular drugs over the counters. They keep taking. Also, we have to inquire about the herbal preparations because most of our patients and general populations believe that herbal preparations are all very safe because it is non-allopathic. They are all safe, but we know that that's not the case. And in fact, I always tell my patients that what we see may not be a true picture, but we have seen the worst of the outcome of the herbal preparations, because when we see the patients, they have either a terminal chronic liver illness or the chronic kidney disease because of the long-term consumption of heavy metals, which is one of the ingredients of many of these so-called basmas. So it's always important that we inquire about this. When it comes to examinations, we must look for koilonychia, because whenever there is a koilonychia, it's a sign of chronic iron deficiency, not acute. If patient loses the lot amount of blood in few days time, he's not going to develop koilonychia. So koilonychia means the disease there for a long time. It indicates chronicity. Likewise, clubbing also suggests that either there could be the chronic illness like either the chronic suppurative illness like the tuberculosis or amyloidosis, or chronic ulcerative colitis, or chronic liver disease, or maybe malignancy or bronchiectasis. So keep in mind another important point that maybe most of our patients are not fair skin, but still there can be pigmentations over the knuckles. If you find the pigmentations over the knuckles, that's a pointer towards the megaloblastic anemia or B12 deficiency. Of course, a patient who is diabetic, it could also be representing acanthosis nigricans, something we have to keep in mind. Likewise, inquire about the stomatitis and angular cirrhosis and jaundice. If a patient has anemia and jaundice, the first thing that I would ask is what is the color of the urine and color of the stool. If the color of the urine is dark, like cola colored, surely we are dealing with a hemolytic jaundice. But if the color is not dark, color is not yellow, so normal or little concentrated urine, again it could be hemolytic jaundice. And we know that hemolytic anemia has a total different causes and the line of management, right? We'll discuss when we discuss the investigations. But jaundice is not the same as jaundice that we see in other patients. Here, we have to keep in mind hemolytic jaundice and whether there are any lymph nodes or hepatosplenomegaly, because the diagnosis change. Patient who has got liver, spleen, and lymph nodes, right? Probably we are thinking of some reticuloendothelial system involvement or chronic generalized infections. So edema, whether it's a pitting or not, again important. And murmur like koilonychia again suggests a long-standing disease. So the point is, these are the points which we can see in a matter of few minutes, but gives a lot of information. When it comes to investigations, these are my preferred list of initial investigations. In any patient of anemia, before we write any medicine, I would go for at least these many investigations. Complete blood counts, which most of would be doing it. But my special emphasis in this particular slide and for all patients with anemia is getting the reticulocyte count and getting the serum creatinine. Because if we miss initially, probably we may not do it later. So get complete blood counts, reticulocyte count, urine analysis, again for anemia, because that's a very, very important indicator, can give informations about the chronic kidney disease. Stool examinations, serum creatinine, SGPT and bilirubin for the liver functions, and random blood sugar. So these are the investigations I would insist for all the patients of anemia. I had just suggested Dr. Darbar that I would be giving this particular presentation in a PDF form for all those who attend. So you may not write down anything or take the pictures of any of this, and you will be given this in the PDF form after this lecture. So what is very important in a family practice is the how to interpret complete blood count report or CBC report. CBC, we know that different laboratories have different concept for CBC. So it's better that we mention what we mean by CBC when we order the blood test CBC. Get hemoglobin, red blood cell counts, RBC indices, WBC, total count, differential count, and platelet counts. And peripheral smear, especially here comes the role of the good microbiologists and pathologists, that they will be able to help us in diagnose so many cases of anemia, but simple, good peripheral smear examinations. And ESR is something very, very important, especially when it is very low or very high. Mildly elevated ESR may not help. So first and foremost is hemoglobin and RBC count. It's better to remember that there are some parameters which are directly measured in any investigations. Hemoglobin is one which is directly measured in grams per deciliter. RBC count is expressed in millions per cubic millimeter. MCV is the mean corpuscular volume or size of the RBC, which is expressed either as femtoliter or picogram or cubic millimeter. This is one investment which can also be derived from the formula. But hemoglobin and RBC count are always measured, and they usually run parallel. Means if the patient has hemoglobin is less, RBC is less. If the RBC is less, hemoglobin is less. If there is contradictory levels, right, there has to be some explanation for that. It cannot be just an error. And when we are talking of anemia, we should know what is the definition of anemia. By WHO, it is less than 12 grams in any patient. But we know that normally what we consider as anemia is males, it is less than 13 grams, and female, it is less than 12 grams. It can vary from the population to population, but by WHO definitions, less than 12 gram in any person is anemia. We don't talk about the newly born children or they have a higher hemoglobin. In general, we are talking of HB less than 12 gram is anemia. So hemoglobin, RBC count are very, very important. There are certain parameters which are calculated parameters. They come from the formula or equations, which is very important. One is hematocrit, or what we call packed cell volume, PCV or hematocrit. Then another is MCH and another is MCHC. MCH represent is mean corpuscular hemoglobin, where MCH is mean corpuscular hemoglobin concentration. We are not going to talk about this because it's always confusing, but remember that MCH is reduced in iron deficiency anemia, thalassemia, while MCHC is increase in macrocytic anemia and spherocytosis. More than that, we don't need to remember that right now. Important thing is this: in hematology, there is what is called a rule of three. This is very, very important, very easy to understand, and very easy to pick up few of the abnormalities. Hemoglobin is always 3 times the RBC count, and hematocrit or PCV or hematocrit is 3 times the hemoglobin value. Both are 3 times, but both are different. RBC count 3 into multiplied by 3 is hemoglobin. Hemoglobin into 3 times is hematocrit. This is very, very important. If there are contradictory results, as I said, hemoglobin is different, RBC is different than expectations, there has to be an artifact, that is either the patient is dehydrated or overhydrated, or whether the sample we have taken after giving the IV fluids or whatever it is, or there is some condition, pathological condition, which has to be investigated. So always check the hemoglobin, hematocrit and RBC count and see whether they follows the normal rule of 3. I'll give the example to understand what we mean by rule of 3. If the patient has hemoglobin is 9 and the same patient's RBC count is 4.5, right? Now, with a hemoglobin of 9, the RBC count we expect is how much?
3.
9 millions, because 3 times. So
3.
9 millions, right? What we expect, 3 millions. 3 millions is what we expect. Instead of 3 million, this patient's RBC count is 4.5. That means the RBC numbers are more than the value of hemoglobin. And this is very, very common in thalassemia trait. Thalassemia trait, this is very common. So whenever you find the disparity between hemoglobin and RBC count, and for the matching hemoglobin, if the RBC count is on the higher side, or in short, whenever the RBC count is almost near normal range, we know that the RBC count is anything from 4 to 5.5 million per cubic millimeter. And if the patient's hemoglobin is 9, 10, 11, we don't expect the RBC count to be on this range. If this is what we find, always think of thalassemia, and we'll see what else we see for confirming thalassemia trait. The other way around, the patient's hemoglobin is 9 and his hematocrit value is 36. Hemoglobin is 9, same hemoglobin we have taken for understanding, but the PCV or hematocrit is 36. What we expect hematocrit to be is 27, because 9 into 3 is 27. But here it is 36, yeah? Here it is 36, which is higher. The PEC cell volume is high because the next to PEC cell volume is the fluid, that is plasma. Plasma is less, right? So PEC cell volume is high. This is because the plasma volume is decreased. This can be because of the patient is dehydrated, because of the diarrhea, vomiting. So it's very important whenever we see hemoglobin, RBC count, hematocrit, we have to see whether they match with the rule of 3 or something else is responsible for this abnormality. And what we see commonly in dengue, what is important is we must get on first day of fever, we always get the CBC. If patient's hemoglobin on day 1 is suppose 11, and next day when we see the hemoglobin, if it is 13, see, nobody's hemoglobin go up by 2 grams or 1 gram or even 0.5 gram next day. Even if we give blood, it will not go more than 1 gram, right? So our hemoglobin has gone up because of hemoconcentration. That is because the dengue pathology is such that there is a capillary leak. That is why the plasma is out of the intravascular compartment. So whenever the patient's hemoglobin go up, right? And that's very, very important for dengue. Your dengue NS1 may be negative, your dengue RT-PCR may be negative. But if the next day hemoglobin is up, the leukocyte counts are less. Among with that, if there is a activated lymphocytes or higher dominance number of lymphocytes, right, and the platelets on the lower side or very low, always think of dengue. So it's very, very important. And very important parameter, the reason is whenever there is a 20% hemoconcentrations, if the patient hemoglobin has grown from 10 to 12, that is 20% hemoconcentration, it is very, very important. There's a volume contraction, and these are the patients who are very likely chance of getting into dengue complications like dengue shock syndrome or dengue hemorrhagic fever. So very important parameter, and simple CBC we can give with what is coming. Another important parameter is mean corpuscular volume or MCV. We know that normal size of the RBCs is 80 to 100 femtoliters. This values may be 76 or 74 in some other laboratories. This value may be 94 or 95 or 105. But by and large, it is 80 to 100 is a normal size of RBCs. And if anything less than 80 femtoliter is microcytic anemia, anything more than 100 is macrocytic anemia. That means the RBCs are smaller here and bigger here. It's very important, and very simple MC we can give idea about whether we are dealing with microcytic anemia, normocytic anemia, or macrocytic anemia. And these are the very important causes of types of anemia. Not the whole list is. Whenever there is a smaller RBC MCV is less than 80 or 70, it's either iron deficiency, thalassemia are the commonest. Chronic disease, chronic infections, tuberculosis, collagen disease can lead to chronic microcytic anemia, and lead poisoning, important, worth keeping in mind. Amongst normocytic, it is an acute blood loss. Some medicines that suppresses the bone marrow can lead to normocytic. Chronic diseases again can have overlapping microcytic or normocytic depending on what stage we pick up this cell abnormality, and infections. Macrocytic anemia are vitamin B12 or folic deficiency, chronic liver disease, hypothyroidism, and hemolytic anemia. So just by looking at the size of the RBCs, we have some now started developing or reducing our list of possible cause of anemia, whether it is microcytic, whether it is normocytic or macrocytic. So we are trying to shortlist the possible way of investigation, what next investigation we should be doing it based on only CBC. If the CBC shows microcytic, we know what investigation we should be looking for. If the CBC shows macrocytic, we know what leaks like to investigations. We can get all investigations on day 1, but that at the cost of the huge expenses. Again, I overemphasize reticulocyte count. In my first list of investigation, I said that CBC, reti count, serum creatinine are very, very important because reticulocyte count is one of the cells which are just before the development of before the RBCs enter the circulations. So this is a stage prior to the fully matured RBC, right? And RBCs are non-nucleated cells. RBCs do not have nucleus. When they are in the bone marrow, they have got nucleus. The last nucleated cell is normoblast. After normoblast in the bone marrow, the reticulocytes are developed, which do not have nucleus, but they have got chromatin material, they have got the RNA material, which makes the RBC a little bigger. Its shape is little longer, bigger, and irregular shape, and there is bluish cytoplasm. So these are the reticulocytes, and these are the reticulocytes which are normally poured into the bone marrow, the peripheral circulations at 1% every day. We know that RBCs have a life cycle of around 120 days. So at least 1 to 1.5% reticulocytes are coming into the circulations, peripheral circulation every day. So it's very, very important we look for the retic count. If reticulocyte counts are reduced, say 0.5% or 0%, that means there is either iron deficiency, aplastic anemia, or chronic infections. So decreased reticulocyte counts are more supposed deficiency or bone marrow problem, but it's what is important is increased reticulocyte count. If the reticulocytes counts are high, it suggests one of the H. Remember 3H increase reticulocyte count. If the patient is bleeding somewhere, losing blood, occult or overt, if patient has hemolysis, or we have started treatment without confirming the diagnosis. As I said, one tablet can make the difference. If the patient has anemia and you started hematinics and then you do retic count, it might be increased. Right. So very important, get the retic count before starting a treatment. Increase reticulocyte count more than 2% is either hemorrhage, hemolysis, or hematinic treatment. So investigations, as I said, complete blood count, reticulocyte counts are very, very important and must be done in all patients of anemia. Urine is equally important. Urine gives so much of information. It can give you about the proteinuria indicating of the glomerular disease, right? Then RBC cast or RBCs or hemoglobinuria or urobilinogen, any of this suggests that there is some either the patient has a chronic kidney disease or there is some indication of hemolysis. If the patient who has got hemoglobinuria, that means there is an intravascular hemolysis, right? So that could be because of one of the hemolytic anemia leading to the hemoglobinuria, paroxysmal nocturnal hemoglobinuria, G6PD deficiency, anywhere there, whenever there is an intravascular hemolysis. Falciparum malaria, it used to be called black water fever, right? People used to blame the quinine, but even malaria itself can produce hemoglobinuria. Stool examinations obviously required for whether there is a blood, there is any ova cyst. Then creatinine is very important, but just a minute more for creatinine. They're just getting creatinine is not enough. While we can get eGFR from only few details that we need, right? Whether estimated GFR, normally it has to be in the range of 90 to 110. But as age advances, after 60, maybe 60 would be normal. But GFR is very, very important. Random plasma glucose is obviously important. SGPT, bilirubin, serum proteins. Serum proteins are important. We have chronic liver disease in mind. Always get the total proteins and albumin globulin ratio. When there is a reversal of albumin globulin ratio, it's a pointer towards the chronic liver disease. Very, very important investigations. The additional investigations are required in all patients of anemia if you have not been able to get the cause or to get the final cause or to rule out additional causes. As in our first patient, we would go for the serum TSH and free T4. We can get total T4, but whenever there is an hypoproteinemia, it's better to go for the free T4. Anti-TPO antibodies will be required only if the patient has T4 is the normal, TSH is above but not above 10, or the picture is not very clear. It's better we get anti-TPO antibodies. And if that is positive, if the TSH is high, if the clinical picture fits with the diagnosis of hypothyroidism, we can start treatment. Otherwise, better that we repeat after another 4 to 6 weeks, TSH and T4. Iron profile, again, very important investigations. Most of the people would reflexly do serum ferritin, but serum ferritin is just a stored protein. It's a protein which stores the iron and will not be depleted unless the whole store is depleted. The serum ferritin is also acute phase reactant. We have seen in all acute conditions like COVID and all, serum ferritin is very high. So it does not clearly give the idea of the iron. Its best thing is to get the serum iron and SIBC, and which gives the transparent saturation percentage. Always ask for transparent saturation percentage. If it is less than 20%, definitely pakka case of iron deficiency. And remember, iron deficiency can exist without anemia. Patient's hemoglobin may be 12 or even 12.5, 13, but his transparent saturation can be low and he definitely deserves iron treatment. So do not think that iron deficiency anemia and iron deficiency has to be existing together or coexist. No, patient can have an iron deficiency without anemia or hemoglobin level less than the normal. B12 levels, of course, we do it when we suspect macrocytic or megaloblastic picture. Hemoglobin electrophoresis is required whenever, as I said, patient has got the RBC count, which is much higher than the proportionate hemoglobin. They are microcytic. Their MC values are very low. Normally in iron deficiency anemia, we'll find the MC values around 70, 72. But if you find 60, 65, 54, that kind of MC values, always think of thalassemia and get the screening test, what is called HbA2. For all thalassemia patients, mostly for patients, younger patients, we would definitely get the thalassemia trait. And if they are in the childbearing or they have children, I would suggest if the mother has thalassemia trait, it is better that we get their children also tested for thalassemia, because allowing the marriage of two thalassemia trait, we are preventing a thalassemia major disease. So very, very important we get, and nowadays it's available free of cost, the thalassemia screening by the Red Cross. So get thalassemia screening whenever one of the parent is having thalassemia trait. Hemoglobin, sickle hemoglobin, when we are suspecting because of the peripheral smear or the tribal background, all those things. Whenever we are suspect hemolysis, then we based on some of the symptoms like the jaundice or dark color urine or increased indirect bilirubin, or patient having certain communities where G6PD is very common. So get the test for hemolysis. G6PD assay has to be done, not in the immediate acute stage of hemolysis, because all the RBCs which are having G6PD deficiency are hemolyzed. So remaining RBCs have good amount of G6PD and it may be falsely normal. So get G6PD assay after some time, maybe after a month. Then we will get the clear picture of the G6PD deficiency. Coombs test when you are suspecting autoimmune hemolytic anemia. LDH is one of the simple investigations for all patients of hemolysis, because when the RBCs are lying, LDH is something which is liberated. Peripheral smear is very important, which can give the idea of our indications for hemolysis in the form of either sickle cell or thalassemia in the form of target cells or teardrop cells, or abnormal cells like the cystocytes and Burr cells and helmet cells, and all different types of cells are seen in hemolysis. When we are suspecting young patients, joint pain, fatigue, weight loss, hair loss, collagen disease, get the screening test in the form of ANA. ANA is something which should be ordered only by nephelometric or immunofluorescence. Don't just write ANA, because the laboratories for cost-cutting reasons will do latex, and that will be lots of false positive tests. So get ANA. If at all we need ANA, get immunofluorescence or nephelometry, or write ANA with titer. Sonography of the abdomen and neck would obviously be required when we are suspecting some abdominal pathology, or when we are looking for hepatosplenomegaly, lymphadenopathy. When the patient has obvious overt or occult blood, we need upper or lower GI-scopy. Bone marrow aspiration, if this stage comes probably, we need to involve the hematologists or the experts for the further workup. Likewise, biopsy may be required for lymph node or liver. So these are all the investigations, especially in our second case when the patient has weight loss, patient has melena, right? Definitely there is a strong suspicion of malignancy. Maybe we need the upper lower GI scopy and further investigations depending on what comes out from that. So this is all about how to approach a case of anemia. Very few lines about the how to manage anemia. Obviously, the first and foremost thing is the cause of anemia, whether there is one cause or many causes. And obviously, we have to start the cause, but also we have to start the treatment for the hematinics once we have confirmed that the patient has what type of anemia patient has. Till we find the cause or and treat the cause simultaneously, we have to start with iron, B12, folic acid, whatever is required. IV iron therapy, whenever the patient is issues of tolerance or other that we'll talk, and always repeat CBC and retic count. Just once we have started hematinics or B complex, after 1 week or 10 days, if there is rise in reticulocyte count, rise in hemoglobin, definitely our treatment has worked. If it is not, we have to look for what is missing and why that patient is not responding. One or two slides for the what iron preparations we should be giving. Which salt? Of course, many salts are available, but any salt, ferrous sulfate is equally good. There are difference in the elemental iron, but it will not make much difference because most of them would give minimum 30 milligram of elemental iron, which is more than enough for if it is absorbed. So preparation of iron is not very important. Important is what the patient tolerates. Most of the patients, the problem is not with the second part, is only the ferrous part. So whatever iron you take, probably either he or she is going to tolerate or not tolerate. But important thing is whenever we prescribe iron, tell them to take it 30 minutes before or 2 hours after the meal. Also instruct them that this is going to give black color to the stool. Always give that, otherwise the patient will come next day કે સાહેબ દવા આપીને ઝાડા થઈ ગયા અથવા તો ઝાડો થવા માંડ્યો, લોહી આવવા માંડ્યો, right? So always tell them that your stool will be colored or clay colored or black colored. Most of the time it's a black colored because of the iron that we are giving. I always tell that I am giving whatever I am giving, only 10% goes to the blood, 90% goes to the stool. That is why the color is black or coffee color or dark color. So don't worry about that, is expected, right? But important thing is take as far as possible on empty stomach, or at least not with milk, calcium, antacids, coffee, or high fiber, because they will prevent the absorption and our treatment will not be effective. We can take iron with vitamin C and orange juice, but it does definitely help in some absorption, but better is to avoid any of the substance as I mentioned. Iron is not easily tolerable in at least 10 to 15% of the patients, and constipation is one of the major side effect. But some patients do complain of metallic taste or but some have diarrhea also. So if these are the patients where they are definitely not tolerating iron, I suggest them to take on alternate day or a smallest possible dose. There are some tablets preparations which are available which is giving only the 30 milligram of elemental iron. We can start with that, right? Or we may give the patient alternate day iron and see whether they tolerate or not. Giving iron 3 times a day is, though some do exist, it doesn't help. It's better to give on single day, because the moment we give iron, there is release of a protein called hepcidin, and that will reduce the further absorption. So the second tablet of iron would not be absorbed with the same concentration as much as the first tablet. So when you give iron, it is better to give one single dose daily, alternate day, or 3 days in a week, rather than giving 3 times a week. Parenteral iron is required when the patient is not tolerating oral iron because of the side effects, or pregnancy when already the patient has nausea, vomiting. Earlier, as I said, heart failure patients, it's better to give parenteral iron, and it works wonders. It's one of the important pillar of management of heart failure. After the standard treatment now, parenteral iron has come a big way in the heart failure management with anemia. Patients who had got gastric bypass surgery, malabsorptions, patients with chronic inflammations, all these patients definitely deserve parenteral iron therapy. And IV preparations are available. Many of them are available. Just this is a list. It is not complete list, and it is not that I advocate any one of them. I'm just giving you from the list of preparations available. Normally, the formula is get the body weight in kg, multiplied by target hemoglobin minus actual hemoglobin, multiplied 2.4 plus 500 for the storage. But what we give in practice is give 500 milligram to 1000 milligram, depending on the degree of hemoglobin and how much rapidly want to increase the hemoglobin. Most of the time, it is a 500 milligram iron. If we give in 50 to 100 ml saline over 15 to 30 minutes. All. We don't have to give over 1 hour. 15 minutes is what they recommend. We usually take up to 30 minutes. And the only thing is some people develop hypotension, or very, very few patients develop anaphylaxis. Very few. That was more common with sucrose preparations and other early preparations. These preparations are not having any of this black box warning or important side effects, but it is better that we keep all the drugs for hypotension and such reactions ready: adrenaline, steroids, and antihistaminics. And till date, not a single patient death has been reported with iron. And giving iron on OPD basis is very much desirable for our patients also and for us also. The iron preparation, the most commonly used is the ferric carboxy maltose called FCM, which is available usually in 10 ml vial, 50 milligram per ml. So it's 500 milligram per dose. We can give iron preparation 500 milligram to 1000 milligram in one shot, but don't repeat more than once in a week. So maybe next week we call the patient for the another 500 milligram to 1000 milligram. These are the commonly available, but there are many more ones. Iron also maltoside also is very good preparations. Again, 500 milligram per the bottle. And third one is the iron sucrose, which obviously now is less preferred because of theoretically the side effect is more than these two. But not that if somebody has tolerated this, definitely it can also be given. And except the hypotension, sometimes the anaphylaxis, there is no side effect. So these are all, any one of them can be given. So again, I repeat, anemia is not a final diagnosis. It's an incomplete diagnosis. There can be more than one cause, more than one type of anemia. And most of the patients do not need hematinics on day one. It's better to investigate first and treat later. Prescribe patients who have with iron B complex do not solve the problem. It might complicate the problem as far as interpretation of the reports are concerned. IV therapy is very safe, but under its option, and there is a source of revenue for the family practitioners. And follow-up investigations are very important to know the success of the treatment or otherwise. So let us all join the National Health Mission for the Anemia Mukt Bharat. Thank you very much for patient hearing. If there are any questions, I'll be happy to answer. Thank you.
Sir, I have one question.
Sure, sure.
The routine OPD માં પેશન્ટ સર આવે ને
Hmm.
તો ક્લિનિકલી આપણે ફેસ ટુ ફેસ જોઈએ તો બહુ પેલ લાગે છે. હવે જસ્ટ જોયા પછી બીજા બધા સાયન્સ ના જોઈએ પણ આપણને લાગે કે આને એનિમિયા છે જ, બરોબર. રે ફર્સ્ટ ટાઈમ CBC કરાવીએ ને તો ઇટ્સ એબ્સોલ્યુટલી નોર્મલ આવે. ઇઝ ધેર એની કોઝ બિહાઇન્ડ ઇટ?
See, usually pale or without anemia, there is the questions we ask in the exam also. But see, the most common could be the complexion itself, because second is the light part, third is the hypothyroidisms. Then patient may have iron deficiency but not anemia. Hypothyroidism, these are the two important. Hypotension, shock. But otherwise, we may have to look for the complete picture and get sometimes the B12 deficiency, folic acid deficiency can also lead to the pale part. So it's very important that we see, evaluate overall, but it's not very common, but definitely we see more with, I would keep in mind hypothyroidism is a strong suspicion whenever there is a pale.
Sir, in these days, we see maximum patient of having a B12 deficiency less than 200 or even less than 100, but their hemoglobin is not that much less. So what could be the reason of that?
So we don't know whether the result is with the B12 as a type of assay that they do it. That could be one reasons, right? But B12 deficiency in most of our patients are otherwise also expected, because most of the patients are strictly vegetarian. So it is expected. We have seen it even in the people who take eggs also. So B12 deficiency could be not only because of the food source, but malabsorption, right? That also could be one reason that that's a problem. But B12 and vitamin D is something I am a big advocate of. B12 and vitamin D in most of the patients. The reason being not the scientific one. It's better to treat them rather than to investigate, because once there is an invest, as you said, it's less than 200. We spend 1200 rupees or 1000 rupees, and the treatment is less expensive than the diagnosis. Same is with the vitamin D. And vitamin D also, we presume that there is a deficiency for the simple reason that even though it's available free, we don't take it. None of us. If your and my vitamin D will also be surely less than 30. So
Definitely.
it's better to treat rather than to look for it. Yes, we don't overtreat it. B12 we overtreat, there is no harm. But that's
But
not
the
scientific.
hemoglobin, but in a blood picture, they don't say any sort of anemia or any cell size difference at all.
That is true, but we also don't look for the iron levels also, and because if there is a bimorphic picture, if the iron and B12 both are deficient, then the peripheral smear picture would not be indicative of either. That is typical dimorphic anemia. That could be one reasons. And again, just like, see, I was just reading about the anemia Bharat statistics, and that more than 68% of Gujarat population has got anemia.
Yes,
Can't believe
definitely.
it. It is so
Yes.
much prevalent that it was really an eye-opener and an excellent initiative by the government. That's why I put it.
But even not related to any socio-economic condition.
Absolutely,
Even though in
absolutely,
rich people or high
absolutely,
educated people, we find anemia in so many prevalence.
absolutely,
So
absolutely.
one more point, sir.
Yeah, sure.
Those so many people are having this masala chewing, orbital and chewing. We see microcytic anemia. Do you think that the oral supplement will work, or we have to go for the parenteral only?
No, I think once we swallow the tablets, right, I don't think it is there is no oral the iron is absorbed straight away in the jejunum. Maybe we need the hydrochloric acid, not only the masala chewing, but probably the widespread use of PPI could also one of the factors for
Yes.
having hypochlorhydria, and that could be one cause of iron, B12, all deficiencies. But orally, I am not sure whether the chronic chewing, metal chewing would lead to the less iron absorption. I am not sure. But to me, probably it's more because of the some GI related betel nut effect on the gastrointestinal systems or the malabsorption part.
But we see many patients who are having this tobacco, masala chewing, and tomato chewing having anemia.
So it's fine. At least we should at least offer them once parenteral therapy and see whether they respond.
Right.
Surely. And as my point was saying, parenteral iron therapy is underutilized.
Okay.
Definitely underutilized. And now that we have got the safer options available, and they do not cost much. If we directly talk with the company walas, probably they will get it around 1,000 rupees, and which is not a big
That
sum.
is
If you
gone down
that
600 to 700 also. It is gone.
Definitely.
What is done.
Sir, is there any particular point, say 1, 8 or 9 hemoglobin, then we have to give iron parenteral therapy?
See, if it's a very good question, but I would say there is no such particular, unless the patient is a pregnant patient. If the patient is pregnant, definitely we would give it, right? If the patients, there also the value that is given is less than 7, right? But otherwise, no particular level. Its important thing is patient is not tolerating oral iron, so patient needs parenteral iron. But not that the parenteral iron would increase, but all that we have to do is at least replace immediately, and the rise in hemoglobin will start 1 to 1.5. It's not that by giving parenteral iron, the hemoglobin will be 10 next month only. No, it doesn't happen. But it's fair enough that the patients would start feeling better from the next week itself. That's what we have seen. At the cellular level, the iron deficiency produces so much of symptoms of fatigue and tiredness and all. That will definitely be better, even if the hemoglobin doesn't rise.
Lesser the hemoglobin, longer the iron treatment. See, totally, if you give prescribe oral prescription to any patient, how much rise will expect in 3 to 4 weeks?
What we expect is around 1 to 2 grams. 1 to 2 grams. So obviously, when I start my hematinics, I would say you have to take minimum for 3 months. But subject to the subsequent investigations, see, once the patient's hemoglobin improve, we expect the other parameters also improve. His appetite will improve, his digestion would improve, and then maybe that hemoglobin on its own, the bone marrow would also be better responding, and maybe that hemoglobin, subsequent rise in hemoglobin, it doesn't require that the continuous hematinic therapy. If he modifies the diet, definitely, but anything from 3 to 6 months would be required to achieve the hemoglobin of 12 grams. Sure.
Sir, one thing we have noted in our private practice that some patient having hemoglobin of 4 or 5 grams and they are refugees for parenteral therapy. Then we started the oral therapy, and within 2 months we got great response, like 8 to 9 gram. Is it possible?
Very much possible. Surely it is possible. Definitely it is possible. Only thing is, if the patient is stable, patient tolerates oral iron, there is no, it's not that, that's why I said there is no particular level of hemoglobin that is required for parenteral therapy. I would
Tolerance
give
is
it at
main.
4 gram also, I'll give it 10 gram also. If the patient has heart failure on 10 gram, surely will need
Yeah.
it. The only thing that we have to keep in
Tolerance.
mind that in chronic kidney disease, we don't try to achieve the hemoglobin of more than 11 gram, because by giving the erythropoietin or something which has its own side effects. So that is where this role of erythropoietin comes. Otherwise, we should try to achieve 12 grams, but not necessarily with the parenteral iron all the time.
Sir,
Sir,
one
in
more
thalassemia
question.
minor,
Only
Yeah.
thing which we have to look for this anemic patient has a compensated heart or not. If there is no any
Absolutely.
cardiac problem, then we can have oral treatment also.
See, normally in the CCF treatment, after the 4 parameters, 4 pillars that say, we give uh, the all these medicines, and then only we'll think of giving parenteral iron, unless the anemia itself is the responsible for angina. See, that's
Okay.
one of the mention. Then it said give, and what we give is only, we can give it in 50 ml also, not that we have to give 100 ml over a period of 15-30 minutes. That would not lead to any effect on the cardiac function. So in fact, that is very much a care that before you discharge the patient of heart failure, you give it. That is how the recommendation, not necessarily in the first or 2 days or 3 days of hospitalizations, but before discharge, make sure that patient goes home with parenteral iron if the hemoglobin is less.
Yes. Okay.
Somebody was asking about
In
thalassemia.
thalassemia minor, we always see the hemoglobin of the patient remains almost below 11 or below 10. It never goes higher than that.
That's true. That's true. That is because see, what is thalassemia minor? Thalassemia minor is a quantitative deficiency of the beta chains. We know that hemoglobin, normal hemoglobin is alpha and beta.
Double chase, alpha
Right.
and beta, yes.
So alpha and beta is supposed to contribute to almost 98-99% of the total hemoglobin. That is called HbA. What is HbA2 is alpha and delta.
Delta.
So that is why we go for the thalassemia minus alpha and delta. Right? Alpha beta is normal HB hemoglobin. Alpha gamma is HbF. That is what is there in the childhood. So in children, you don't diagnose this, because otherwise also in children there is HbF, and that is why if there is thalassemia minor, they will not have symptoms. Thalassemia major, there is no beta chain. So the children live only on fetal hemoglobin. So within 6 months only their blood transfusion requirement will start.
Yes.
Sir, one question. That you have said that subclinical hypothyroidism is TSH is high and T3, T4 is normal. Suppose free T4 is normal. Once we did that at that time 6 TSH, and then after 9 or 3 times after 1 or 3 months. If we needed to do anti-TPO antibody, when we needed to do?
Yes. See, if the patient has persistent symptoms of fatigue, constipations, weight gain, right, and not accountable to any other reasons, and T4 is in the near normal range, but the TSH is higher, at least I would go for the anti-TPO, because the Hashimoto's thyroiditis is one of the commonest cause of primary hypothyroidism, and where anti-TPO, the problem, Kamlesh Bhai, is that people keep on doing anti-TPO. It's not required. If it is high, it's high. Right. Once we start, we don't need to do anti-TPO. But once we definitely do, if it's very high, surely we can start, because in the course of next 3 to 6 months, patient would develop hypertension, and you are justified unless patient is elderly. There, you have both subclinical hypo and subclinical hyperthyroidism, both are dangerous. Subclinical hypothyroidism can lead to heart failure. Subclinical hyperthyroidism can lead to atrial fibrillation. So we have to be very careful about this. And we start at a very small dose, 12.5 microgram of thyroxine, and repeat after 6 weeks. So that is one condition where we have to be a little careful. Otherwise, definitely in subclinical hypothyroidism, strong suspicion, and with positive anti-TPO, I would start with the treatment. And the treatment,
sometimes some endocrinologists prescribe in subclinical hypothyroidism alternate day low dose. Is there true or not?
Not to my knowledge that there is such treatment, because, but at least what we see, contrary to what we practice here, that in USA people take thyroxine at night.
Yeah.
So it's not that it has to be taken in the morning. I see last week only I saw a patient because they could not take on empty stomach. They had not taken for 4 weeks. So that's not required. What is important is it's not empty stomach, but when you take thyroxine, don't take calcium, iron, B12. Any of these which can affect the thyroxine absorption. Food, little tea, coffee would not make a big difference. It's better to take that with a 90% absorption than not taking it, right? So telling that patient has to take it on the empty stomach, fasting and all, well, that is why many of the patients do not take it. But definitely no iron, no B12, no calcium with iron. That is definite instruction we should be giving.
I think
Except three ferrous, sir, एक question.
Yeah, sure.
एक ज minute.
No
Except
problem. Yeah.
No, sir, time is problem. Ferrous sulfate, ferrous gluconate, ferrous fumarate, few bisglycinate or carbonyl. Is there any role or a special role?
See, definitely there is a difference in the absorptions, right? And the tolerance, that is what they say. We can try. I would say if the ferrous sulfate doesn't work, I would definitely try another, right? If there is no severe constipation with the first. So there is no harm in trying different if the patient is an objection or the hemoglobin is not that low that we have to start with parenteral. I do not suggest that parenteral iron therapy if the patient doesn't tolerate any level of hemoglobin. But definitely we try different salts, and I always end up by saying that the most neglected anemia is a mild anemia. 6 gram, everybody, patient also ready, we are also ready, but 11 gram we just don't take. Yeah, that is what my point is, that don't neglect mild anemia. Majority of the patients has mild anemia, not severe anemia.
I think
Thank you very much. Sir, finish karijo.
Sure.
Thank you very much, Dr. Mahadevbhai Desai, sir.
Dhiren, you want to say anything?
No, but just main thing is that Dr. Mahadevbhai is our mentor and a real teacher for us, and we always learn something new at every time from him. So we really give you very much respect to you, sir. Thank you so much.
Thank you. I enjoyed, and I also learned so many things while preparing this. I always believe that the best thing is to learn is to teach.
Right.
Yeah. Thank you very much, sir. We enjoy, we learn so many things from you and this session also. Thank you, Dr. Darbar, sir. And once again, we will meet next month.
See, now with that, we conclude the session. Our next session will be on 26 December, that is Thursday again. And the topic will be mostly edema. Thank you all. And we conclude the session. Thank you, Mahadevbhai, and thank you all for
Thank you.
listening.
Thank you so much. Thank you, sir. Good evening.
Thank you.